I'm Professor Molly, and in this video, we're going to show you how to do a lung assessment and then discuss what normal and abnormal breath sounds sound like. All right, let's go. So let's talk about auscultation of breath sounds. So when you're listening for breath sounds, you want to listen anteriorly first, and then you want to instruct your patient to take a full deep breath in and a full expiratory breath out, and listen to that full breath in each area. As you're doing this, you're going to compare the side that you're listening to and then directly go to the opposite side and listen in that same spot. That way you can see if there's any difference between that area on the other side. So don't forget the lateral areas. Your lobes do go to the lateral sides and over the trachea. Your trachea is where you would hear your stridor. When you're listening to the posterior back, you will hear the scapula up in the scapular area. You will hear the bronchiovesicular sounds. And then again, you're moving from side to side, listening for the full inspiratory and expiratory breath on each side. As you're doing this, don't forget to move laterally and at the bases of the lungs. It's important because you can notice any diminished breath sound, which can be a symptom of atelectasis or consolidation. All right, normal breath sounds are heard in the three normal areas. You've got the bronchial area, which is over the large airway. This is over the neck region. This is heard on expiration. E is for expiration. And you can hear a little bit of inspiration, but if you just listen with the stethoscope over your trachea, you're going to hear this on expiration. And this sounds like a hollow sound. Then if you're going to listen to the bronchiovesicular, that is where you're going to hear both left and right bronchial main stem branches. And this is going to sound low and hollow, a little different than your bronchial, which is going to be a little higher. And this is heard on both inspiration and expiration. You can listen to this in the mid-sternal area where the sternum is. It is to the right and to the left of it, around the third or fourth intercostal space down, is heard best to listen to the bronchiovesicular. Then you're going to go to the vesicular. This is the lung lobes. This is all areas of the lung lobes, and you can see there's a big region of this. If you put your stethoscope on the lobes, you are going to hear this best in an inspiration. You will rarely hear a big noise and volume on expiration, which makes it different when you're listening to abnormal breath sounds, because when you start hearing things on expiration in your lobes, that means there's something going on in your lungs, and we'll talk about in this next slide. So vesicular is heard on inspiration, and you can listen to your lungs to hear this. Again, can start at the top of the clavicle, and you can listen to all areas of your lungs bilaterally and anterior and posteriorly, especially at the bases. So that's the lobes of the lungs. All right, let's go ahead and jump right into abnormal breath sounds. And we're going to talk about rhonchi first, because this is what most people go to. They either document scattered rhonchi or just rhonchi. And you're not wrong if you probably do this, because they probably do have some rhonchi, because you see it in patients with COPD and also anybody that's fluid overloaded, cystic fibrosis, heart failure. Sometimes this happens when you get a lot of mucus in your large airway. Best heard over your trachea and over your right and left main stem bronchi. So this will be more of a bronchial or bronchial vesicular sound. It's not going to be necessarily in a vesicular sound, because now we've moved out of the large airway. So people say it also sounds like snoring, and this is what it sounds like. The thing is with rhonchi is that you can clear it, and you can clear it with a cough, or you can suction it out. Now let's move on to crackles and rales. So this one is kind of interchangeable. You can use this when you document, because rales are considered a little bit more like fine crackles. So mostly crackles are defined as fine, coarse. They can be dry or moist, and it can sound like fire crackling. It also can sound like a rocks being moved around, people with pulmonary edema, asthma, heart failure. Again, this is a lot of things with fluid. This is high-pitched sounds, and it's the air trying to move in the alveoli, and it's trying to overcome that air because it's filled with mucus or it's surrounded by a lot of mucus. So this is what crackles sound like. And let's now go into wheezes. Wheezes seem to be, I think, my favorite because they are high-pitched musical sounds, and they do sound like a high-pitched musical sound. This is heard when a sound is trying to move through a narrow airway. I really like to hear this when I'm listening to my asthma patients because it does remind me that their bronchioles are constricting, and it's hard for them to move airway out. So sometimes you hear it a lot on the expiration. You can hear wheezing on inspiration, but a lot of times you're going to hear it on the expiration. These are tight, narrow airways. Again, this is not typically to do with fluid and to do with your alveoli with a lot of mucus that you will see with the rales and the rhonchi, like pneumonia. This is the tight bronchitis, asthma, your emphysema patients, tight airway. So again, this is what wheezing sounds like. And you can hear it mostly through the exhale. And whenever you give a medication like a corticosteroid, and then you go and listen to them afterwards, or you give them a bronchodilator, it is very interesting to go and reassess them. And they typically, the wheezing can be gone. So listen to your patients before and after. This is a good way to assess that if your interventions were effective. Now, stridor is a little different. You can hear this with kids, or you can also hear this with adults, especially if you extubate somebody, which is meaning pulling the an endotracheal tube out because their airway can close off or narrow. And this is also when food gets stuck in your throat, and your epiglottitis when you have a narrowing of the epiglottis. So this is a very high-pitched sound. It sounds like your airway is narrowing and you cannot breathe. This is a medical emergency and it has to be treated immediately. This is what it sounds like. I hope that makes sense, and that is the end of this little session, and I hope that you have happy listening. Have a great day.